website for posterity. So thanks so much, everyone, for coming. You're here because you're writing the Royal College in March, and I'm going to spend the next 59 minutes, not a moment longer, giving you a crash course in a high yield epi for the Royal College. So I'm only focusing on stuff that comes up for the Royal College. We're going to skip topics that might be fundamental epi, but it doesn't come up, so I'm not going to discuss it. And this event is brought to you in part by Medicine Pods. All of you know what the website is because you went to the website to sign up. So thanks for doing that. Before I get too deep in, my disclosures are here. I've received some honorariums for journals. I'm a paid editor at Medium Evidence. I've been part of 2 startup companies, and I have grant support from these agencies here. So as mentioned, Medicine Pods is a new initiative that's been launched by Allison Lai, Zara Morali, Leah Karianopoulos, my brother John Freilich, and Justin Boyle. We hope it'll be a one-stop shop for all things internal medicine. So we have the Roundtable podcast, the Intern at Work podcast, Room for the Royal College. This is high yield rheumatology for the Royal College. So I would definitely recommend checking that out, as well as trial files and some need to know videos. Speaking of trial files, this is created by my lab. It's a free newsletter. I will just mute everyone. I'll put the link in the chat there. But if people want to sign up, it provides updates on practice-changing trials summarized using a large language model and delivered to your inbox. So as mentioned, this is everything you need to know for your Royal College exam. Feel free to stop me if you have questions, and we'll keep it high yield. Some basic terms: exposure, outcome, bias, and a confounder. What's an exposure? Often it's that thing you want to study. I'm curious about SGLT2s and the risk of DKA. Okay, SGLT2 is the exposure, and the outcome in that example would be diabetic ketoacidosis. Bias and confounder, these are concepts that often get confused. All right. So confounder and confounding by indication, those are all underneath the umbrella term of bias. So bias is some systematic error that results in an incorrect estimate of the association between an exposure and an outcome. I'll bring that to life shortly. A confounder is something that could be associated with both the exposure and the outcome, which can cause bias, but is not on the causal pathway. So let's bring this to life. So do yellow fingers cause lung cancer? Okay, so in this poorly crafted research question, the exposure is yellow fingernails. The outcome is lung cancer. But we can all acknowledge, no. It's not that the yellow fingers cause lung cancer. It's that smoking cause both yellow fingers and lung cancer. So we would call smoking a confounder. All right. So this is the incorrect association that we're drawing when instead you have smoking causing both. All right. The main 2 types of confounders are measured and unmeasured. I'll mention very soon why this is important. But if the Royal College ever asks, what does randomization balance? It balances both measured and unmeasured confounders. Okay, so it balances both. I'm just gonna, if everyone can mute themselves, that'd be perfect. Thanks for doing that. In the example we just talked about, the exposure here, when we correctly state our research question, is smoking. Smoking leads to DNA damage, and eventually that can lead to lung cancer. So you never want to adjust for things that are on the causal pathway. You wouldn't adjust away mutations. So anything that's on the causal pathway, you would not want to adjust for. And when you're thinking about confounders, they are associated with your exposure or outcome, and sometimes both. Let's talk about study design. So a common question that comes up on the Royal College exam: how do we avoid selection bias? All right, how do we avoid selection bias? And what I mean by selection bias is, I really like SGLT2 inhibitors. if you're my patient, there's a good chance I'm going to prescribe you an SGLT2 inhibitor. Okay. Now, there could be a bias there. Maybe Mike Freilich, the fact that he prescribes SGLT2 a lot, maybe that's also associated with something else, right? I don't know. Maybe I'm not good with other stuff in medicine. And then patients have a worse outcome. Okay. So maybe it wasn't the SGLT2. Maybe it was Mike Freilich. So, how do we avoid that? You toss a coin. Heads, you get an SGLT2. Tails, you don't get an SGLT2. A very powerful way to remove and avoid selection bias. So that is part of the magic of randomization. It markedly reduces selection bias. And as mentioned, it balances measured confounders. How come? The distribution of smoking, whether you got the drug or the placebo, will be the same in the two groups as long as your randomized trial was large enough. And the real magic of randomized trials, it will also balance unmeasured confounders. So if on the Royal College exam they say what study design can balance unmeasured confounders, it's always randomization and nothing else.
Yeah, I'm not understand.
So here's a question. You're researching a new medication for C. diff. What is the best way to limit selection bias? So A, randomize patients. B, ensure the clinical trial statistical power. C, can't remember. D, blind both investigators and participants. People can put in the chat what they think the answer is, and it'll just be a good test to see if anyone's listening out there. Okay, thank you. Randomization. Well done. Thank you, Carla. Thank you for humoring me. That's correct. Okay. Another question here. You're reading a randomized controlled trial on fresh plasma versus old plasma to determine if there's a difference in mortality. The study is designed to detect a difference of 15%. 7.8% of participants in the fresh blood arm died, and 8.4% of participants in the old blood arm died. What is true? Recruitment was 1-to-1. The event rate in the old blood arm was approximately double the fresh blood arm. C, you cannot exclude the null hypothesis in this trial. Do people want to put in the chat what they think the answer is? C, yeah, well done. Exactly. Good job. Yeah, you cannot exclude the null hypothesis. The event rate in the old arm, event rate is just code for what your primary outcome was. So clearly, the primary outcome was almost identical in the two groups, 7.8% and 8.4%. So that's wrong. Recruitment was performed on a 1-to-1 basis. The way you would confirm that would be if they're the exact same or almost the exact same number of patients in the plasma versus fresh blood arm. And that clearly wasn't the case here. So yeah, C is the right answer. So just to hammer home the power of a randomized trial. In a randomized trial such as this one, your confounders, age, sex, race, etc., will be balanced in the two groups, right? So you will achieve balance in your measured confounders. And as I mentioned, the real magic is that even the things it didn't measure will be balanced. So if you have some annoying peer reviewer that says, oh, what about if they have prior DKA or some made up gene? Well, angry peer reviewer, that's going to be balanced in the two groups because the only thing that determines who got the drug and who got the placebo was just random chance. I hope that makes sense. If it doesn't, feel free to ask a question. And of course, the way that we make sure the two groups are balanced is the randomized trial has to be large enough. So just like how you could flip a coin 10 times and it shows up heads 8 times in a row, it's just random chance. But if you flip that coin 1,000 times, if you have 1,000 patients in your clinical trial, you expect the characteristics to be balanced. So we can contrast that with why is blinding helpful? Randomization, we learned the benefits of it, balances measured confounders, unmeasured confounders, markedly reduces selection bias. Blinding helps to prevent outcome adjudication bias. And it also helps to prevent that patients don't change their behavior. So in this clinical trial of a vaccine for COVID, it was placebo controlled. If it wasn't, maybe patients that didn't get the jab, maybe they start acting differently. I don't know, maybe there were clues. Maybe they don't go outside. Maybe they don't interact with people. And those characteristics might affect the risk of the outcome. So, why is blinding helpful? It prevents treatment ascertainment bias. That's how you ascertain the outcome in your clinical trial. A researcher has to determine, okay, did this patient have the outcome, yes or no? And you hope that that researcher is blinded so that they can't impress upon what they think might be going on as they adjudicate the outcome. And it helps to prevent behavioral biases, behavioral changes your patient might make. So, long question. How would you minimize ascertainment bias? One, randomization. Two, blinding the investigators and the patients. Three, using intention to treat. Or four, wrong answer. People want to put in the chat what they think the answer is here. Okay. Yeah, exactly. Blinding. That's perfect. Intention to treat. I don't think that's ever been the correct answer on a Royal College exam. So let's keep going. All right. Another concept that comes up is non-inferiority results. There's a 5-minute version of this talk on YouTube if you want a reminder. But of course, I'll walk you through everything you need to know right now. So, in general, 95% of all clinical trials fall into two buckets: superiority. Is this drug better than placebo? Is this drug better than some other medication? And then the other maybe 15% of the time is non-inferiority. Is drug X not inferior to placebo? Uh, Said differently, is it good enough? Is it as good as? Is it not worse than? But I'll be the first to acknowledge it's confusing. And maybe if people just mute themselves, I think somebody's unmuted, or Kat, if you can mute them. This is a nice paper if you want a 2-page summary on non-inferiority trials, but I suspect you don't have an abundance of time to be reading manuscripts. So this is what you call a forest plot, okay? And this will be super helpful for you to be familiar with. So here we're looking at the ratio of the event rate between some treatment and some active control. And just give me 1 second. Somebody is not muted. Okay, I think that muted them. Magic. Okay, thanks. When you're looking at a forest plot, and you might not be looking at it, but you can draw this on your Royal College exam for a sanity check to make sure you're selecting the right answer. So anything to the left of one means a drug works. Anything to the right of arm means a drug hurts. This is the point estimate, and this line is a 95% confidence intervals. Okay, so this applies to any relative risk, whether the study says rate ratio, risk ratio, odds ratio, hazard ratio, anything with the word ratio after. So in this case, we would say the drug is superior, right? It's great. The point estimate is to the left of the line of unity, and the 95% confidence interval excludes the null. Now, in a non-inferiority study, they'll tell you what the margin is. They might say, listen, the non-inferiority margin was 20%. That's the same as saying 1.2. Who comes up with the margin? Sometimes it's the FDA, sometimes it's the researchers, sometimes through other mechanisms. So for this study here, we would call this non-inferior and superior. Why would we call it non-inferior? It's non-inferior as long as the confidence interval does not cross the dashed line. Okay, I repeat, as long as the confidence interval does not cross a dashed line, you can say something is non-inferior. And we can say that it is superior because the 95% confidence interval doesn't cross the line of unity. Okay, so this example here, we would call it non-inferior. How come? Because the upper bound does not touch the dashed line. Okay, that's as simple as it gets. And then we have other instances which we can sort of briefly walk through here. So this one is non-inferior. How come? Because it doesn't touch the dashed line. It ain't superior. It's actually inferior because the bottom part of the confidence interval crosses 1, right? And this is on the bad side of the outcome. This is inconclusive because the confidence interval touches both. And this one is inferior. Okay, we can't say it's non-inferior because it touches a dashed line. Not the most straightforward terminology, um, but don't shoot the messenger. Okay, so let's go to the next slide. Um, a randomized controlled trial sought to determine if a generic drug is non-inferior to a brand name drug. The non-inferiority margin was set at 20%. There are the results. Why don't people take a moment and see if you can figure out what the answer is here? But I don't just take 2 minutes. Okay, and I won't put anyone on the spot, I promise, but we can just draw this to bring it to life. So we learn that the hazard ratio is 0.94, the confidence interval is this, the p-value is that, and that's a non-inferiority margin. So first, we can draw our point estimate. Then we can draw our line, and we know it goes from 0.84 to 1.08. So it does not cross the non-inferiority margin, and we would call this, drum roll please, non-inferior. Does that make sense? Any questions that people have?
I have a quick question. The p-value in this case is related to if you're trying to determine if it's superior, even if the study design is a non-inferiority trial. Is that correct?
Great question. The p-value for non-inferiority is one p-value, and then if it's non-inferior, then the investigators get another p-value, and that second p-value is for superiority. Okay, let's go through another example. This one is tricky. So why don't people pause, read the slide, and see if you can select the right answer. Okay, so I'd recommend, the day of the Royal College, just write this out, double asterisks. People had trouble with this one. Okay, they said a margin of 2%. Huh. Okay. Investigators said a 2% difference in risk. Huh. Okay, something's going on here. This is kind of different than the other questions. The study showed 3% risk of bad stuff. Okay, the results of the study note a 3% absolute risk increase in the study outcome with confidence intervals of -1 to 7%. Okay, they did something tricky here. So let's bring this figure back up. When you have a ratio estimate, the line of unity is 1. When you have an absolute estimate, look at that big O there. Okay, that's 0. The line of unity, when it's an absolute risk, is 0. So an extra bit of trickiness there. But now we can just draw out the results as they were received. So we know the margin's at 2%. We know the confidence interval spans from -1 to 7%. So we can see in this case, we can't say it's not inferior. It touches a dashed line. And you know what? It's an inconclusive result because it's touching both the line of unity and the dashed line. Any questions there? Okay, we'll keep going. So in this for this question, you would say the results of the study are uninterpretable. Hopefully, the actual thing would say like inconclusive. We've talked on RCTs, and we should talk on the drawbacks of RCTs. So the major one is external generalizability, right? That's a number one drawback to randomized trials. Are they going to generalize to the patient you're caring for on the GIM ward? Well, probably not if this clinical trial was done among healthy, wealthy outpatients. It probably won't generalize. So that's one major limitation. Also, randomized trials are only powered to detect their primary outcome. All right. And very often, randomized trials have an inability to detect rare adverse events because they are rare. So, bringing that to life, you're seeing a patient with COVID who has an indication for a DEX. The patient wants to know the risk of AVN, assuming they meet the inclusion criteria for the study. What is the best type of study to answer your patient's question? So, do people want to put in the chat, what do you think is the best way to answer this question? And DEX is dexamethasone, not a DEXA scan. Oh, three answers. This is great. Okay, let's see. How do you know it was relative risk in that question? Oh, sorry, Carl, sorry, your question. Because it said absolute risk. So when it's relative risk, it has to have the word ratio. It has to have the word ratio in there. Can you go over how you understand whether it's an absolute versus relative risk? Yeah, so in a relative risk, they'll just be describing a ratio, a risk ratio, odds ratio, and anything ratio. Whereas if it's an absolute risk difference, they will say the risk difference is blank. Yeah, great meta-analysis. That's perfect. So cross-sectional study. Those aren't definitely not going to be good to determine the risks of dexamethasone. Randomized trial. Nope, 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 nope. Randomized trials are underpowered for adverse events. Randomized trials are particularly trying to determine, does this drug work? A meta-analysis. Yep, that just means they're gathering many different types of studies together. Decision analysis. That is never the right answer on the Royal College. So just to reiterate that, avoid circling that. Okay, always. What is a decision analysis? That's understanding the cost effectiveness of a new drug. So for study types, the big categories are randomized trials and observational studies. One example of an observational study is an ecological study that examines the association between exposure and outcome on a population level. The unit of measurement is the population. Okay, so an example here, all people in Canada who ate a tomato in 1850, 100% mortality rate by 2020. Okay, and for that reason, I'm not going to eat any tomatoes. Another example here, you can look at chocolate consumption on the x-axis and Nobel laureates on the y-axis. The Swiss love their chocolate, and they're doing pretty good when it comes to Nobel Prizes. Okay, China doesn't seem to like chocolates, or maybe not reporting the data, and doesn't really seem to be winning many Nobel Prizes. Is this causal? Of course not. Of course not. Okay. So in these cross-sectional studies, you can almost never draw cause and effect. Um, Cross-sectional studies. So most ecological studies are just a type of cross-sectional study. I can make that more clear next time. But in a given cross-sectional study, the individuals are not followed over time. So it's one single cross-section, one single point in time. The most common use is a diagnostic study. So you have some new test for COVID-19. You're going to do the test. You're also going to do PCR and see, is it concordant? Is it discordant? You're not following the patient up over time. All right. So that is the most common use, one of the most common uses of a cross-sectional study in clinical medicine. And here's just a great example from Dr. Schulzberg and Dr. Arya. If you want some nice examples of high quality cross-sectional studies. So what a cross-sectional study gives you is this 2x2 table. This can take a bit of time to get your head around here. But as mentioned, with some, let's say, new diagnostic tests for COVID, the test's either positive or negative, and the patient either truly has COVID or they do not have COVID. So if the test is positive and they truly have COVID, that's a true positive. If the test is negative, but they had COVID, that's a false negative. If the test is negative and they don't have COVID, that's a true negative. And if the test is positive, but they don't have COVID, that's a false positive. So, as I think you all know, this comes up on the Royal College exam. This is a formula for sensitivity and specificity. And the mnemonic acronym, I don't know what you'd call this, like SNOUT, a highly sensitive test is good at ruling out, whereas a specific test spin is good to rule in. I have a master's and a PhD in epi, and I still need to Google the formula for sensitivity and specificity, okay? So don't feel bad if that's you as well. Other formulas that you need to know are positive predictive value. Well, that's a lot of P's. True positive divided by true positive plus false positive. Okay, so PPV. And then NPV or negative predictive value, true negatives divided by true negatives plus false negatives. So let's come up with an example. We have a new test that is available to diagnose COVID. It's compared to the gold standard of PCR. So maybe if people want to just jot down this and see if you can work this out on your own, I'll stop talking so you can read the slide and see if you can get the answer. Okay, so why don't I help you out here? So when we read all this, okay, let's see how we can put this 2x2 table together. So we hear that there are 200 patients with COVID. Okay, cool. So that's 200. Of 200 patients with COVID, 180 test positive with the new test. Okay, that's 180 true positives. We can just do some simple math, and that means this number is 20. Then we find out there's 300 patients who didn't have COVID. Okay, cool. So that's going to be the total 300. 60 test positive with the new test. Well, that's a false positive. We can do some basic math. 300 minus 60 is 240. And it asks for the positive predictive value, which again, lots of P's, true positive divided by true positive plus false positives. So the answer there would be 75%. I'll pause for a second and see if anyone has any questions. And on the Royal College exam, if you're like me, you'll be a little bit nervous, and that's okay. Slow down when you get to these questions. Slow down when you get to these questions and just write things out. Do the basics. Otherwise, you might just get a bit frazzled and pick an answer and then keep going. All right, another 2x2 table. So a new screening test developed for COVID. The test was developed using a population of 1,000 patients. Okay, so our whole study is 1,000. The prevalence of COVID in the population is 10%. 10% of 1,000, it's 100. Okay, there's 100 people who truly have COVID. The test has a specificity of 90%, and 90 patients who have COVID will have a negative test. What is the sensitivity of the test? So, like I said, it's easy to be like, I have no clue. Let's just keep it simple and let's break down the numbers and fill in our 2x2 table. So they told us there's a total of 1,000 patients, okay? And they also told us that 10% have COVID. So that means there's 100 people there. 1,000 minus 100 is 900, okay? We can keep chipping away. The test has a specificity of 90%, and 90 patients who have COVID will have a negative test. So now we can fill in here our false negative, and then we can very easily calculate our true positives. Okay. And then we can calculate our sensitivity. I'll just go back one slide. So the formula for sensitivity is true positives divided by true positives plus false negatives. Okay. And this is our final answer. So 10 out of 100, so 10%. I'll pause for a second and just see if anyone has a question. Just check the chat. Cool. Okay, we look good. Some other formulas, error rate. If error rate ever comes up, that's false negatives plus false positives equals everyone. All the false stuff, okay? All the false stuff over everyone. That's N is total sample. Accuracy rate, true positives plus true negatives divided by all individuals. positive likelihood ratio, a negative likelihood ratio. I don't think these are coming up, so I won't say anything more about them. Uh, so, so you're aware, how do these likelihood ratios even work? All the time in medicine, you're seeing some patients and you're coming up with a pre-test probability. You get the consult from the emerge doc and they say, hey, I got this 80-year-old person and they're coughing. You're making a pre-test probability in your mind, 80 years old and coughing. This is probably going to be uh, pneumonia or maybe a viral infection or maybe heart failure. I'm not sure, but this is the pretest probability you're making. So very often the pretest probabilities are based on the characteristics of the patient, age, sex, the symptoms they have, the past history they have. Okay. Sometimes it's based on prevalence. So right now in Toronto, rates of influenza A are quite high. The prevalence of influenza A being high, that should probably inform what you think might be going on with a patient. And then every diagnostic test has a likelihood ratio, whether you know it or not. Okay, it has a likelihood ratio, and depending on what the pretest probability is. So let's say I don't know, you have like a 20% pretest probability that this person might have influenza A. Well, let's just make up that a positive influenza A test as like a likelihood ratio of 100. So what you would do is you would draw the line from your pretest probability of 20% through the likelihood ratio of 100, and you'd have like a post-test probability, like a 95% probability that what you're dealing with here is influenza A. You aren't going to see this chart on your Royal College exam, but at least now, hopefully, you understand a bit on how likelihood ratios of a diagnostic test are related to pre-test probability and post-test probability. And what's important to highlight, if you have an extremely high pretest probability, there's a 99% probability that this referral that I'm about to get, I don't know, let's just say this patient has heart failure. They're swollen, they've gained weight, they have a note from their cardiologist saying this is heart failure. When you have an extremely high pretest probability, no matter how good the test is, even if the test is bad, very often you're still going to have a very high post-test probability. So this is all a function in how likely it is that the disease you think is in front of you is truly in front of you. All right, so moving on, we talked about cross-sectional studies. Next, we'll talk about cohort studies. So what is a cohort study? This is often confused and mixed up. A cohort study is defined by a cohort entry event, and people are followed over time. Okay, so, a cohort of medical students, that's their defining event, and we're going to follow them through med school and see how they do. Okay, this is a cohort study. Everyone who's at this talk today, if at the end of this talk there's an evaluation and you give me a score from 0 to 1,000,000, and that's it, this is cross-sectional. If instead in 6 months from now I send you a follow-up survey, and if you're kind enough to do it, I won't send you a survey, I promise, then that's a cohort. All right, so a cohort study is there's some cohort entry event and people are followed over time. So just as one example, it might be one drug versus another drug, and then patients are followed forward. Do they get a fracture if they're on an SGLT2 inhibitor? Very often, well, ideally, very often in a really high quality epidemiologic study, you're comparing the new use of one drug to the new use of another drug. So whenever you see a study that's comparing, drug A versus no medication, in general, that will be so prone to bias because, as all of you know, as resident physicians, for patients that we decide to give them a medication, prescribe them some new medication, they're going to be very different than the same patient who we round on and we say, oh, no, I'm not starting them on anything new. Maybe they're too sick. Maybe they're palliative. Maybe they have contraindications for the medications. So what does a cohort study give you? This sometimes comes up. What a cohort study gives you, it gives you both estimates of relative risk and also absolute risk. So if that question comes up, a cohort study gives you both. You can calculate absolute risk and you can calculate relative risk. How do I know if it's a relative risk? As we mentioned, it'll have the word ratio in it. Another formula that comes up is a relative risk increase, and we'll go through this in a subsequent slide. I think the slide isn't as helpful as I thought it would be, so let me just jump to one aspect that is. So sometimes questions come up and it says, like, what result do you get from a case control study? The result you get from a case control study is an odds ratio. All right, that is the important teaching point and pearl you need to know for the Royal College exam. Whereas in contrast, in a cohort study, you get a measure of absolute risk difference as well as relative risk. So how do I calculate absolute risk for when it comes up? So your absolute risk is the event rate in your control group minus the event rate in your exposure group. Okay, so the control event rate minus the exposed event rate. That is your absolute risk. If you need to calculate a number needed to treat, it's 1 divided by the absolute risk that you calculated here. Number needed to harm, you're just flipping exposed with control. Let's do an example. So I'll pause here, and if people want to take a look at this question and jot down what they think the answer is. Any guesses what the answer is here? Shy group, that's okay. All right, let's try to work through this together. So what is the event rate in the control arm? It's 1400 divided by 2800. Wait, how'd you get that? So remember that the total in our control group is the 1400 who are alive and the 1400 who died. All right, so 1400 divided by 2800 is 0.5. And then in the intervention arm, same thing, 600 divided by the total. So 600 divided by 800. You can subtract the two of those and get 0.25, and 1 divided by 0.25 is 4. I'll just pause to see if anyone has questions.
I have a question, please. Why not the other way around? Like, why not the dead people in the intervention minus the dead people in the control?
Sorry, just give me 1 second. It sounds like there's a party going on downstairs. Just give me. Sorry about that. Do you want to ask that question again?
Yeah, sure. Why not the other way around? Like, why not how many people died in the intervention group versus how many people died in the control group?
Yeah. So this is asking for the number needed to treat. So the number needed to treat is going to be 1 divided by your the absolute risk improvement, I guess you could call it. If it was number needed to harm, then you would do it the other way around. And let me fact check myself on that as well. Just give me 1 second.
Yeah, sure.
Yeah, okay, because it's so number needed to treat. So we're looking at like a benefit here. So how many people lived? That's why you do 1400 divided by 2800 in the control. And then same thing in the intervention arm, 600, the people who lived, divided by 800.
Because I thought like the number need to treat is like how many people do I need to treat to prevent one harm?
That's number needed to harm. The number needed to treat is how many people do you have to treat to observe that beneficial outcome. So, like as an example, if you had a study that looked at SGLT2s and the risk of heart failure, and you found that there was a 5% absolute risk reduction in your bad outcome in being hospitalized with heart failure, that it would be 1 divided by 5% or 1 divided by 0.05, which is 20. So you would need to treat 20 people to avoid one bad outcome.
Okay, thank you.
Yeah, no worries. It's like terrifying trying to do mental math on the spot. Okay, anyway, let's keep going. How do I calculate a relative risk ratio? So this is your event rate in the control group minus the exposure event rate divided by the control event rate. I don't know if this has come up recently. Maybe 10 years ago when I wrote this, there was like one question on it. I removed it because it was terribly complicated. So, but I'm happy to answer questions at the end if people have any. So the last study type is case control study. I'm going to jump to the punchlines, what you actually need to know. For your own understanding, remember, this is a cohort study. You have some drug and some other drug, and people are followed forward in time. And you see, who had the outcome and who did not. In a case control study, you're looking at cases. That's people who broke their bone, controls, people who did not break their bone, and looking backwards to see who was exposed with what. But the most common question that comes up is, what result do you get from a case control study? And the answer is an odds ratio. That's it. There's one other type of a case control study. There's actually many other types, but they don't come up on the Royal College exam, so I won't waste any more breath. Comparing case control and cohort studies. Some of this we've already really discussed. I'll highlight the most important points. So as mentioned, in a case control study, it only gives you an odds ratio. And in a cohort study, you can get your risk ratios. These are all relative risks, as well as the absolute risk difference. I don't know if this has come up before, but case control studies are technically more efficient. They're more efficient than a cohort study. How are you going to remember that? Efficiency, and there's an E in case control. Yeah, that'll do. The risk of bias is similar between the two, which can provide you with an absolute risk estimate, as mentioned, just a cohort study. I'll pause here to see if there's any questions. All right, keep going. I'll spend a couple minutes on this and drive home the teaching point about p-values because that's what comes up. So odds versus probability. So probability is just success divided by all possible events. Odds are a good outcome divided by the bad outcome. Again, let's bring this to life. I got a sweet tooth. I like candy. Okay. So if somebody says, hey, Mike, in this bag of candy, there's 3 red jujubes, my favorite, 2 yellow, 1 black. I would ask myself, what's the probability of a red jujube? Okay. And as mentioned, a probability is success. What I define success, red jujube, divided by all possible outcomes. Okay. So that's 3 divided by 6. There's a 50% probability of me picking a red jujube. In contrast, what are the odds of a red? It's a good outcome divided by the bad outcome. So the odds are 1 to 1. Why do we have odds? Mainly for betting. Okay. So odds are, if you put in $1, here's the amount you're going to get back. All right. So with 1 to 1 odds, you put $1 in, you're going to get $1 back. If the odds are 10 to 1, you put $1 in. And if your horse wins the race, you get $10. Okay. 10 to 1 odds. Oh, that's nice. Great. Where's he going with this? I'll get to it. I promise. Okay. So a quick summary, rate is when there's time in the denominator. Let's just ignore that for now. Risk is the same as probability. So whenever you hear the word risk, you can think of that as being synonymous with probability. Odds ratio, as mentioned, is confusing. And really what you need to know is that a case control gives you an odds ratio. And hopefully I gave you a little bit of intuition about odds in general, but I acknowledge it's not the most clear thing. And relative risk is an umbrella term. So a relative risk can include anything that ends in the word ratio. Absolute risk or absolute risk difference, the important teaching points for your Royal College. Number one is that for a non-inferiority study, that line of unity becomes 0. And you remember that because there's a big O in absolute. That a cohort study that can be used to calculate absolute risk, but a case control cannot. I'll just pause for a second and see if there's any burning questions. So something else that comes up is sometimes a multiple choice comparing experimental studies to observational. Experimental is just the same as saying randomized trial. So why don't they just call it randomized trial? I don't know, but people like to make things confusing. So comparing and contrasting randomized trials, as mentioned, they are very good at controlling and balancing baseline confounders. With an observational study, it's highly variable. Time varying confounding, unless you have blinding, patients might change their behavior and do something different. It's impossible to control for time varying confounding in an observational study, or almost impossible. Internal validity of a randomized trial, generally high. Observational can be highly variable. The external generalizability of randomized trials is often low. How come? Because most clinical trials are recruiting the healthiest and wealthiest patients, and that might not be a reflection of the person who you're caring for on a general internal medicine ward. Mortal time bias, just ignore that. Risk of selection bias, randomized trials is low. Observational can be quite high. How come? Because in an observational study, who gets the drug and who doesn't get the drug is probably highly related to patient level characteristics or provider level characteristics. And unless it was a randomized trial, odds are those biases might explain any differences you observe in the study results. We're nearing the end, I promise. What is a p-value? Okay, this is a tricky one. A, probability that the observed hypothesis is true. B, probability that the data were produced by random chance alone. C, the effect size of an intervention. D, probability under a specified model that the result would be equal to or more extreme than its observed value. People want to take some guesses in the chat. Okay, it's getting late. I'll read the room. I'll keep going. So here the answer is D. Okay, so a probability has the p-value, pardon me, has nothing to do with how likely the observed result was because of chance alone. That's a common misconception. It also doesn't have anything to do with the effect size of the intervention. When we say effect size, usually we mean, by how much does it reduce heart failure hospitalizations? By how much does it reduce mortality? It's a probability under a specified model that the result be equal to or more extreme than its observed value. You don't have time for reading stuff, but this is a really nice summary of it. And then I have a 6-minute summary video on what a p-value is. It's publicly available on YouTube in case that's helpful. Okay, next up, what is a 95% confidence interval? The range of values that you can be 95% confident contains a true mean. the probability that a given 95% confidence interval contains a true value. The 95% confidence interval predicts that 95% of the estimates from future studies fall inside the observed interval. If we were to repeat the study 100 times, approximately 95 of the 100 confidence intervals will contain the true mean value. Any brave souls that want to guess what this one is in the chat? So the biggest misconception is that it's a probability that a given 95% confidence interval contains a true value. That's not correct. It's this here, D. If we were to repeat the study 100 times, approximately 95 of those studies, their confidence intervals would contain the true mean value. The reason why this is important is if you go to Google, the first hit on Google is wrong. Hopefully the first hit on like ChatGPT is correct. But same thing, we have a 6-minute video on 95% confidence intervals in case you're like, what the heck is he talking about? So 6 takeaway points, hopefully from the past 55 minutes. The best way to prevent bias confounding from the purview of the Royal College exam is a randomized trial. The best way to prevent ascertainment bias is blinding. Okay, the researcher needs to be blinded so that he or she does not know what the patient got. A cohort study, it's defined as some cohort defining event, and people are followed over time. Case control study, all you need to know is that it gives you an odds ratio and nothing else. A 95% confidence interval. If you repeat the study 100 times, then approximately 95 of the 100 confidence intervals will contain the true mean value. P-values are confusing, but they're a probability under a specified model that the result would be equal to or more extreme than its observed value. That was a whirlwind 55 some odd minutes. I'm happy to try to answer any questions that people have. The recording will be on the MedPod's website. Yeah, no problem at all. And I'll just very quickly put in the chat the non-inferiority video that we made a few years ago, which hopefully will be helpful. And you can just check on YouTube for the p-value. Yeah, no problem, BG. Thanks for coming.